Welcome back. This is lesson 2 of Neurodiversity Affirming Care. In this section, we are going to spend some time focusing on how we can integrate some skills and integrate some of the information that we talked about in lesson 1 into practice. And I kind of always like to start in a place of foundationally engaging compassionate care, which we'll talk a little bit about as we go through this section. I am starting with a quote. When I do these trainings, I always kind of will go on Google Images and, kind of look up things that I can include. And this one just really sat with me a little bit, especially in the context of this training. And it says, "I do not suffer from autism, but I do suffer from the way you treat me." This was written by Tyler Durden, and it was quoted in Autism Parenting Magazine in 2021. They actually did an entire article quoting and kind of representing autistic individuals and their experience in service. So I would recommend you to look at it. I can't speak for the entire issue, but that article in general is pretty good to read. I think that it's important to start in this place because I think we're really talking about the way that our services and individuals interact with autistic individuals really can determine progress and risk and harm as we move forward, or as people get older and, kind of come in contact with the service providers in BCBA and ABA, therapy, medical providers, really kind of thinking about the broad range of services that people receive. One thing that I often talk to my autistic clients about when they come in for treatment is, and I'll talk to parents and stakeholders, and I'll often say, we're not here to pathologize autism. So people aren't coming into my office. They are not engaging in ABA services because they're autistic. People are seeking out services because they're experiencing challenges in their community and they're looking for support. And so I think it's really important when we are providing care that we keep that in mind. So thinking about the last few weeks, and then I was, updating the slides on this training, and I was reflecting on a conversation I had in supervision with somebody that I provide supervision for. And we were talking about a staff person leaving at the place that they work and that they support a lot of clients who are within the neuromajority, but also have autistic clients that are on their caseload. And this person had, not my supervisee, but one of their peers had told all of their caseload that they were leaving like 6-7 weeks prior to their termination date. And they have one autistic client that they hadn't told yet, and they had one more appointment left. And the conversation that, kind of occurred within their team was the assumption that the autistic client wouldn't understand, or that the autistic client would really struggle, with the transition and, wouldn't be able to handle the news. And so we have this situation where the clients that were within what's considered the neuromajority received appropriate information that the person was leaving. They received time to process the transition out of services. The clients were part of a conversation about what follow-up care would look like. And the one client who was autistic was not part of that conversation. And so we really start to look at, where ableism falls into how we're engaging and supporting our autistic clients and our clients who are, within the neurodiverse kind of community. And I just highlight that, I kind of live in a place that all opportunities are opportunities for us to learn. Unfortunately, this staff is not my supervisee and works at a different agency, but worked with my supervisee around how they can provide support and direction for this staff and trainings. But I really think that it's important to, recognize how sometimes we may be trying to act as providers in the best interest, or what we believe is the best interest. But when we pathologize autism, we are contributing to some of the challenges that our autistic clients face when they are working in, in ABA services, therapy, medical services, and things like that. So I just bring that up because I think it gives us a place of where to start. I genuinely believe that if we are open to learning and developing and growing as humans and BCBAs and, kind of whatever role we come into contact with individuals in, then we already have a really good place to start. So we're going to talk a little bit about some of the research. We're going to talk a little bit about some specific skills that we can engage in as practitioners. I, mentioned in lesson one that it's really important to listen to the autistic community about what their needs and their experiences are. And then our job is to educate ourselves to meet the needs of the community that we're working with. It's not the autistic community's job to necessarily provide that training and teaching unless they want to, but it is our job as BCBAs to make sure that we're seeking out that information. So thinking about where we start, we're really looking at how we are providing care and services to the individuals that we are working with. And I think compassionate care really highlights where it's important for us to practice from. It's a philosophical kind of approach and a behavioral approach to how we're providing services to the people that we're working with. So I threw in some definitions that I got from some of the research articles. All of the references are included in the course if you're interested in kind of doing a little extra reading on your own. But for today, we're talking about compassion is really when we, as humans, can recognize, have an emotional relationship with, and empathy for another person's experience. So we are able to provide support and understanding if someone is coming to us and talking about their suffering, their pain, if they're talking about what their motivation and behavior or their relationships look like. And then, as humans, we have an ability to kind of sit with somebody, which I know is such a therapy term, but to be in space with someone and provide support and care from a compassionate perspective. Empathy is part of compassion. So empathy alone is really kind of that term of walking in another person's shoes. So being able to kind of understand or feel what somebody's feeling, and compassion kind of goes a little bit further than that. So it does include empathy. Um, when we're talking about compassion and empathy, we're looking at two pieces. So there's our cognitive perspective, so how we think about the things that we're hearing, how we think about what people are sharing with us. And then there is what they call an affective component. So this is how we appreciate and experience the other person's emotional response. So we have private events that occur when we are, working with individuals who are coming to us for help. And then the behavioral part is what we do with our private events, with those cognitions and with that affect that we're experiencing. So compassionate care is a collaborative approach that's based on, I'll just kind of read through the slide. So it's based on the ability to experience and to act on our compassion. So what are the behaviors that we're doing to show and, support people in our own compassion for their experience? It is based on our ability to collaborate and communicate and partner with our patients and clients, their family members, stakeholders, to the extent that that person needs and wants, right? So this is where I may have compassion and want to engage in service that I think might be the best. But if somebody says, no, thank you, then how am I using my compassion and my collaboration to really work with my clients to make sure that the services I am providing are what they need and want? It's based on the commitment of everyone who works in healthcare to communicate and collaborate with each other. So when I talk about healthcare, I'm really talking about all of the services that our autistic clients may be accessing. So, I've worked with individuals who are meeting with an occupational therapist and a physical therapist and a speech and language provider. They have special education at school, right? They have caregivers. So we start to think about, this broad perspective of how we as professionals start to communicate with others about the clients that we're working with, right? So it's looking at language even, we've I spend a lot of time talking about engagement, right? So, when clients are struggling to engage in services or people aren't showing up for appointments, it's the difference between thinking this person doesn't want services or they're just not following through to, wow, this family has a lot going on. They have 10 service providers and, addition to school that they're accessing. That must be so fatiguing and hard to organize all of those appointments. So it's really kind of thinking about, and then what's the behavior I do? If I believe somebody's purposefully not coming into services, my behavior may look like, trying to close them out of services. It may look like when I get supervision or peer consultation that I'm not speaking as supportively about a client versus thinking, wow, this family or this client has a lot going on and that must be really hard. I might be more likely to reach out and to problem solve, to work with other providers to decide like, okay, this client has, 7 appointments this week. How do we help the family manage this in a more effective way? So really, that's the behavior that we see associated with collaborative, compassionate care. And then the last part is compassionate care is based on the resilience and well-being of both the professional and the family or caregivers, as well as the client, right? So if we are all not kind of working on the same page, if I'm not aware as a BCBA where I might be experiencing compassion fatigue or burnout, if I'm not engaging in the care that I need to for myself, it's hard for me to engage in compassionate care for the clients that I'm supporting. So we won't get too far into compassion fatigue, because that really is where we head when we're feeling overwhelmed and overworked. There are some really good trainings that Master ABA has around how to manage compassion fatigue and, kind of manage our schedules and organization and all of those things. I encourage you to check them out. The other piece that is really important to think about in regards to compassionate care is talking about how we're providing the interventions we're providing and how we're getting consent or assent for those. We'll talk about that in a little bit, but the requirements under compassionate care for ABA is really looking at attempting to understand the function of somebody's behavior, right? That's kind of our bread and butter in ABA. We're always thinking about what is this behavior telling us? Looking at that behavior in a compassionate way, and then asking the client, asking the family members, what are your goals, but taking into account everything, right? We're engaging in assessment that's supportive. We're looking at interventions that are positive and teaching skills versus, punishment. So really thinking about those things can be helpful. So when we're thinking about behaviors specifically that are associated with compassionate care, honestly, the list is not exhaustive. There is tons of research out there in multiple different kind of service fields about how we teach compassion and how we train in compassionate care. So these are just a couple things for us to think about as we are integrating, services and talking with clients and families. I learned a really long time ago, because this first bullet point, I'm gonna say introduce ourselves. And a lot of people, like when I do supervision, are like, well, yeah, of course I introduce myself. I'm Nikki, and this is, nice to meet you. But when we're talking about introductions, we're really talking about providing information about who you might be as a BCBA. So now, depending on what service I'm providing, I might say, hi, my name's Nikki. I'm a BCBA, and then I'll explain what that means. Sometimes, depending on my, people's comfort, you might want to share what your pronouns are. So I'll say, my pronouns are she, her, hers. I go back and I'll ask, do you have pronouns that you would like me to use, right? So we're creating this opportunity for introduction that starts to build a relationship. And we'll talk about kind of that relationship piece as we go on. Foundationally, building relationship is probably the most important part of any relationships in service that we have with our autistic clients, or with clients that you're serving if you aren't working with autistic individuals. I always appreciated the kind of exercise of think about the best supervisor you've ever had. And think about the behaviors that supervisor engaged in. And then think about the worst boss that you've ever had, because I feel like we've all had a boss that probably is not the most supportive. And what are the behaviors that they engaged in that let you know that they were not engaging, that they were not supportive or really working on the relationship, right? So if I think about my best boss ever, it was somebody who, connected with me with humor because I like to use humor. It was someone who, when I was speaking, was oriented in their body towards me. I'm not somebody who makes a lot of direct eye contact. So I personally don't need that in a relationship, but some people might. Um, it's somebody who, as I'm talking, might engage in some nodding, right? Or back channeling is the verbal, like, vocalizations we make. Yeah. Oh, really? Okay. Right. Thinking about those things that show interest that I'm, listening to what you're saying. Um, it can look at like it just acknowledging the efforts or the strengths and abilities of your client and their family or caregivers. A lot of times people are seeking out ABA services because they are experiencing struggles. So most people don't walk in our door saying, everything's perfect. I don't really need to learn anything new. I'm fine in all my environments, right? Most people are coming into service because they need help with something. And so sometimes our assessments and our conversations are very deficit based, right? Because that's the medical model that we live in. The, kind of social model is looking at what are your strengths? What kind of resources do you have? I will ask families what their resources look like. I had a conversation the other day with a parent of an autistic client I'm working on in services, and I asked the parent. I said, what do you do for fun? What are the things that you do to help manage some of the stress that you're feeling? And the parent like broke into tears, like just like big sobbing, and I'm like, oh my gosh. Inside, I was like, what did I do? Like, what did I say? And I'm like going through, and she goes, that is the first time in the last 3 years that somebody asked me how I was doing. And like really thinking about how important that is for the family in that 30 seconds of communication, that rapport between me and the parent was significantly strengthened. And it gives us more opportunity to have flexibility and collaboration in our relationship to support their child. So really thinking about what interests am I showing in my clients? What interests am I showing in their caregivers if I'm working with them? What interests am I showing in regard to anybody else who might be involved? So building those relationships can really help with the compassionate care piece. Um, and it allows us to join with the family and our clients. So joining is that kind of building relationship. You'll see it kind of listed as like building rapport, like joining in relationship, collaborative care, right? We're talking about how we are showing that we are here for everybody who's involved in a supportive manner and in a compassionate manner. Um, and, sometimes we can do this even through validation. So when we have um, our clients or caretakers who are sitting with us and they're telling of a struggle they're experiencing, even validating back, saying, that sounds like it was really hard. Or, I can imagine that was really difficult for you, are ways that we can start to build rapport and relationship with our clients and our families. And then the last piece that I wanted to include here is engaging in trauma assumed care. Um, I was joking with Amy that like sometimes I feel like I do these trainings and I just want to put like so much information in them, but we'd be here for like 9 hours and I don't know what the map would look like. But trauma assumed care is something that the ABA literature is just starting to touch upon. It's something that's, just starting to come into ABA. There's a ton of literature in other fields, especially the field of psychology and social work. But it's really looking at us, approaching our families, our clients, stakeholders with the assumption that At some point in their life, they may have encountered traumatic stress. And if I can approach families and clients in that manner, I'm more likely to ask, how can I help you? Than I am to ask, what is wrong with you? And then I'm more likely to engage in environmental management, interventions, conversation that really support the fact that I'm assuming that trauma may have occurred. Now, that doesn't mean that everybody has traumatic exposure in their life, but what it means is that I'm providing the same compassionate care to everybody, regardless. And I don't have to try and guess because sometimes people don't talk to us about traumatic events that have occurred in their life. Um, so I, included two of the articles that a lot of this is included in. They're in the ABA, literature. So there's definitely more information and more behaviors, but kind of a to-do for integrating into care is thinking about how am I connecting with the people I'm working with? How am I connecting with my peers, right? How am I connecting with the people that I'm working with in the, community that are collateral supports for our clients? Um, I was trying to find the article because I had used it in another training that I did, but it looked at the impact that building rapport and relationship has on treatment outcomes. And without positive relationships, and we're going to talk about what's called unconditional positive regard in just a second. But without that, treatment outcomes are significantly lower. They're not as like treatment is not as successful as it is if we spend time building relationships. So I would rather spend multiple sessions doing assessment and conversation and talking about what life looks like and what hopes and dreams are and what, goals are client centered than I would to just jump right into intervention. So really just thinking, and again, balancing, right? Because if you're dealing with insurance companies, we have to kind of live in this place where, we're seeking that out. And I will tell you that insurance companies and the way that we have to write language, and I'm going to talk about it in a little bit, is not supportive of compassionate care or trauma assumed care. Um, so I really love reading about the kind of idea of unconditional positive regard in how we build relationships. Um, so the American Psychological Association defines unconditional positive regard as an attitude. So we're talking about private events of caring, acceptance, and prizing or recognizing that others um, expression towards their like individual self is really important. And then our job is like kind of highlighting it. So how do we give attention and positive, interactions? How are we focusing on reinforcement? Can really impact how our relationship develops with others. The thing to kind of think about for unconditional positive regard, it came out of the humanistic approach. So if anyone's heard of Carl Rogers, I feel like if you ever took a psychology 101 course, you learned about like kind of humans have universal needs and their universal need is to connect with others. And then how do we do that in kind of a humanistic approach? In ABA, we're talking about providing pretty much non-contingent reinforcement to our clients in a way that will help us build relationship. So we're not just giving positive, reinforcement or attention to somebody based off of them doing something we expect or learning a skill or engaging in an activity. We're really looking at building relationship that is not contingent on behavior. And I think I think that non-contingent reinforcement can be a really strong use of reinforcement and intervention as long as we're using it, according to plan and correctly and with permission and agreement and conversation with our clients and their caregivers. Um, so I won't go too far into this because there's not a ton of ABA operational definitions around like unconditional positive regard. But I really, encourage people to think about how, or if you're using non-contingent reinforcement and really looking at how that can be used to build relationships and positive rapport with your clients. So in lesson one, we talked about ableism. And I think I made a joke that like, as I was talking about it, I was getting like all passionate about ableism and how we can start to address and identify it. I shared some personal experiences. I think it's important to, when I do these trainings, to really talk about like the fact that I am human too, and that I am learning, and I engage in behaviors that I think I engage with good intention, but it's really what is the person's experience of my behaviors. So when we're addressing ableism in our practice, I think I mentioned this before, but kind of asking ourselves, is an intervention that I'm using um, seek to modify a given trait because it is considered autistic or is considered not appropriate or not functional by the neuromajority? Or am I working to support the client in, meeting their goals? Am I targeting things that are only like intrinsically harmful? So, when we're talking about really significant risk, we may approach those situations different. I still believe in informed consent about all the things that we're doing. We should be talking to our clients and and their caregivers about why we're doing what we're doing, and making sure that we have agreement. Um, and then, kind of also thinking about when we are engaging with others, are we making decisions that are based off of our own assumptions of that individual's experience as an autistic person without the person's input? Um, so when we are looking at addressing ableism, and I mentioned the Neiman article in the first lesson, he talks about how we can be aware of this and start to look at it in ABA and engaging in compassionate care. Part of it is that we are looking to affirm the autistic individual's experience. We're looking to affirm their identity as an autistic individual. And then we're looking to work in collaboration with our clients to make sure that the things that we're working on are what they want and need to work on. Um, when ableism and compassionate care are looked at in the research, um, when they, kind of think about how we're developing relationships, a lot of things focus on relationships with caregivers. And there are significantly less research around how we are providing compassionate care to our identified client. And I think that that's really important. And, I mentioned in lesson one that we're like kind of in this middle place, right? ABA is such a new field of science compared to other like fields of science. And so we're now in this like learning place of like identifying the things we need to shift, pulling from other fields of science and then applying it to our work that we do. And so, one thing that a lot of the literature is looking at around ableism is, are we effectively addressing compassionate care specifically to our identified client, or are we always looking to caregivers to speak for the clients that we're working with? Do we look to professionals that are speaking for the clients that we're working with? And I'm going to talk a little bit in a minute about like Ascent, because I do think that, my experience, I have some clients I work with who are able to communicate, vocally. And then I have other clients who are not able to engage in vocal communication. And then how do we start to assess, you know, their engagement in treatment? Um, and so when we're thinking about identifying ableism, it really starts in a place of self-reflection. I'm going to talk about an idea called social location in a little bit and walk you through what that might look like. But that is one really good way to start to identify if I am engaging in ableist behaviors, if I'm experiencing thoughts that might be ableist. I go back to the example I shared at the beginning of this lesson. There was a lot of ableism and, bias that was occurring in that transition for that staff out from service. It doesn't mean that people can't leave. It doesn't mean that people, don't transition providers. But when we have 14 clients that we engage in one intervention with or one way of communicating, and then we have one client that we shift that because they are autistic, there's a foundational, kind of ableism concern that's happening in that behavior. And so when we're thinking about how we integrate this into practice, I really encourage people, and when I work in supervision around this, is starting to identify, even just foundationally, what are my beliefs about autistic individuals? What is my understanding of autism? How do I communicate in my sessions with my client, with my caregivers? Um, am I addressing when I hear things that might be maybe ableist? So sometimes I'll talk with community providers and they'll say, oh, this individual will never fill in the blank. And I just have such a hard time with never and always. And because I can't see 10 years into the future. So I don't know that somebody will never engage in something. Or, I'll talk with collaterals who are like, we need to work on socialization. And then, like I mentioned, in lesson one, I talked to a client and they're like, I really don't want to do that. It causes me significant distress and it's not a goal of mine. I'm okay not having lots and lots of friends. I'm okay having the 3 friends that I have because we have a lot in common and that's manageable. And so if I'm approaching my clients saying, this person says we need to work on social skills. So here's what we're going to do to work on social skills. And I don't ask my client what they want to do in terms of social skills. Again, I just want to assess, right? Did I why am I engaging in that behavior? Is it possibly, ableistic? And then how do I start to engage in ways to shift my behavior and then kind of, assess and, check what I'm doing. So I think that the other part of this too is to recognize that we're all always learning. Because I don't have lived experience as an autistic person, I am more likely to engage in behaviors and belief systems that are ableist. And the biggest difference is, am I open to learning where I need to do some shifting in that? Um, so when we talk about services that we are providing, one way that we can be aware of ableistic, behaviors and statements, and then also if I'm providing affirming care, is being aware of, again, my behavior. So am I aware of my language? And I'm going to talk a little bit about language, I think in 2 slides. Am I aware of how I'm speaking with individuals? Am I addressing my clients directly? Am I respectful in what diversity might mean? The word diversity in and of itself is made up of a whole bunch of individuals who live within a community, and all of those individuals who are part of a community all have individual differences, wants, needs. So if I approach autism or autistic individuals with an umbrella, that I'm not really recognizing diversity, because within a community, there are individual people who function individually. And so our job as BCBAs is to assess each individual person, right? We don't paste and copy and paste behavior plans, right? We write individualized behavior plans for each person who comes in. We don't copy paste assessments, right? We're doing our own assessments to make sure that we're understanding behavior, because behavior looks different in different contexts and with different people sometimes. So just making sure that we're recognizing that even our understanding of neurodiversity is individualized. I've mentioned this probably a bunch of times, and I think I said in lesson 1, if you take anything from this training, it's, are you listening to the autistic advocates? Are you listening to your autistic clients? And I think one of the biggest things that we can do is to listen and learn and grow, right? That's kind of where we sit. And maybe I just like learning and reading and all of those things. And I think it's an important part of how we practice ABA. I mentioned earlier kind of unconditional positive regard. So neurodiversity affirming care requires not only prioritizing the person unconditionally, but also supporting that individual in in identifying what their identity is, and then supporting what identity might look like. Other than trauma assumed care, in neurodiversity affirming care, I encourage us not to assume. There have been many times in my career where maybe I get like a testing report or I speak with a caregiver first, right? Because they're calling for services before I speak with a client. And it's our human nature to build certain assumptions based off of information we have. If our information is limited or our information is incorrect, then the assumptions that we're building are also potentially not going to be a good match for our clients. And so how are we kind of including everybody and working to not assume that we know something until we have full information about it? I was reading, it was kind of an op-ed and not in a peer-reviewed journal, but it was an autistic individual talking about their support in not ABA services, but in mental health services. And they had mentioned that one of the things that really meant a lot to them is knowing that their provider was somebody who engaged regularly with organizations that were important to the client. So, are we connecting with organizations that help us grow and educate ourselves, but also help us connect with the autistic population? Seeking out education. So I'm hoping that everyone here, right, we are seeking education. I'm hoping that after this training that you continue to seek education because things are always changing. There's always new information out there. If I only read peer-reviewed articles from the 1990s, I'm not going to be educated on kind of what current best practices, and ethically that is something that we are to do as BCBAs. So are we learning about issues for autistic community if we or for whichever kind of whoever we're working with for clients, right? Are we educating about neurodiversity? And then asking how you can help. um it's so hard. I joke with Amy sometimes, like, I've been a therapist for so long, so sometimes I have to like correct myself for like ABA, but I also think that there's this really nice merge. So when I have somebody walk in my office for the first time, I will ask them, for everybody who comes in, to tell me why they're here. And then I immediately kind of start with strengths and hopes. And then I ask them, how do you think I can help you? Before I even start talking about any of the kind of things that are going on that are a challenge. And what it does, I think, in my experience and per, kind of feedback from a lot of the clients I've worked with, is it allows for us to start off on a very hopeful, right, problem solving, future oriented perspective versus starting off in all these things aren't going well, and then everybody's, kind of not seeing where the hope part is. When we ask somebody how we can help, it gives them the option to tell us why we can help them versus me assuming why I can help somebody. Um, when we are doing that, we have opportunity to engage in some of the things I said before, so validating and connecting. But it also allows for us to validate and show that we believe what people's experiences are as autistic individuals. And it also gives us opportunity to learn about that individual's needs and how we might be providing accommodations and understanding and learning for our specific clients that are sitting in the room with us. Um, and then, I always kind of think about making sure that when I'm talking about language, that I am asking people what their preference is in regard to what do you prefer to be called, right? I have a client I work with who refuses to call their parent mom or dad. I won't give too much information because I don't ever want to, break confidentiality, and they call them by their first name. And the family's okay with this. And so when I refer to that parent, I also refer to that parent by their first name, because my client has asked me to do that. Um, have I grown up in a house where I call my mom, mom, and my dad, dad? Absolutely. But my values are not the same as everyone who walks in my office, and like really working to how I can respect, and show support for those values. Um, so I kind of put this in here I wasn't sure like where to put the slide. It seems like a little in the middle, but I think it's important here before we start talking about language and like those things to talk a little bit about this kind of term, the neurodiversity paradigm. Um, and so this, in my understanding and in a lot of the reading I did is what the neurodiversity movement really is based on. And so it's referring to this framework that is emerging everywhere, but all, in ABA, it's very much emerging for how, so it's framework for how we understand an individual's cognitive variations, engagement in the environment looking different, what people consider their own ability, so their strengths and areas they, identify that they need to work on. And really is again looking at that shift away from the medical model. So we're not necessarily normalizing behaviors or validating behaviors to the neuromajority. We are providing support and normalizing within the context of neurodiversity. And so, really thinking about how diversity in and of itself is what we're normalizing versus what the neuromajority might consider appropriate behaviors. Um, so, there's been some implementation of neurodiversity affirming care and this paradigm in um, more cultural like trainings and representation, but it's still kind of hitting barriers in systems issues, right? Or systems policy. So, when we think about social justice and if people are talking about this, we're really thinking about the behaviors that we engage in that help support neurodiversity affirming care within the context of the organizations that we work with. Um, so when we are supporting our clients, what are we also doing to educate our peers? How are we supporting the people that we work with in accessing neuroaffirming and neurodivergent affirming information and supports? How are we calling out or, kind of providing corrective feedback to individuals if we hear ableist language? And, how are we supporting people in listening to the voices of autistic individuals? So, I think that when we are able to start to have language that is supportive of any culturally, any cultural community, any diverse community, the treatment outcomes increase significantly. People feel more joy in treatment, right? They feel more joy in the relationships that they build with us as BCBAs. And I think that that's just a really important thing to kind of think about. All right. So talking a little bit about language. And I think that I get very stuck on language, so I'm not going to spend 700 hours here, but I do think that there's a lot when we are communicating with others. And I'm talking about language. We're going to talk about like vocal language, but I'm going to talk about language in this concept of like even how we communicate with body language with other people, how we communicate through behaviors of choice, right? We're really thinking about language and communication in this broad sense. I mentioned before that the autistic community does talk a lot about identity first. So stating autistic individual. I have clients that will say autistics, right, in regards to their fellow autistic friends or peers or their community versus a person diagnosed with autism. I live in a place of asking. I think I mentioned this before, but a lot of people still prefer, a lot of people I meet with still prefer a person diagnosed with autism. I do find over time when I engage in neurodiversity affirming care that that language is something that a lot of people have heard for many, many years. And sometimes when we're exposed to a way that other people believe kind of consistently, it's hard not to have some internalized stigma around. And so sometimes my work, if it's something that my client wants to work on, is what is identity? What does that mean to you in my therapy world? And in a behavioral context, what are the environments that we can have help our clients contact that help support building identity, building self-confidence, building self-efficacy. Um, and Amy knows that I love to talk about soft skills because I think we focus so much in our training in schools on how do I provide, interventions? What is reinforcement? How am I writing, behavior plans and doing functional behavior assessments? And we don't always look as much in like how we can um like analyze and build intervention in around building like self-efficacy or self-confidence. And sometimes language and how we help our clients identify their identity really can help build that kind of competence and um, positive self-regard and all of those things. Um, so thinking about language, diagnosis is a very medical term. Diagnosis indicates that there may be deficits or that something is not okay. And, the autistic community really is looking at, they discovered, right? So I've had somebody coming out, I discovered 6 months ago that I am autistic, right? So they, like kind of having this cool, like conception of like, who am I? And oh, here's a part of who I am. And this is like the community I connect with versus here are your symptoms and deficits, and this is why you are diagnosed with autism. So again, just kind of thinking about how we're using language when we're speaking with not just our autistic clients, but everybody that we are working with who may engage with autistic individuals. Um, kind of looking at the autistic experience versus being autistic. It's almost like, we need to be aware that we're not trying to separate out autism from the person, right? So if we're doing identity kind of first language, um, this could mean that people experience differences in their sensory worlds. People have experiences in regards to communication. People may have autistic experiences in how they think about things, how they socialize, how they engage in day-to-day living activities. And so kind of prospectively, there's no one perspective of being autistic. And so when we talk about a person's experience versus them being something, we open up the doors to have conversations and have more effective assessments about language and about communication style and about, functions of behavior. And it moves us a little bit more away from the medical model. Um, being aware even just for language around problem behavior versus challenging behavior. Or I had a client who the language we used was, this is a situation I have a hard time in, right? And that was the language they wanted to use. I know that we're talking about possibly challenging behavior or, where I'm going to probably provide some support because the client identified that was an area they wanted to work on. But their language was, this is a situation I have a hard time in. And I was like, that's cool. And so that's how we talked about it. And so I was aware of that language in every interaction I had that was with or for like that, the client I was working with. And just prospectively, I think back, if somebody told me that I had problem behavior, problem, it's hard not to start to feel like I am the problem or being autistic or, being an autistic individual is the problem, or my experience as in the autistic community is a problem, right? So we're really looking at moving away from this deficit-based language. And this is something that I learned when I was doing some research, because I've always used the term like nonverbal. I don't know, it's like in a lot of our literature and the autistic community, at least what I'm reading and learning, there's been a shift to looking at using the term like non-vocal or minimally vocal, because people still engage in verbal behavior, even if it's not vocal. And so it helps even just reframe how we are looking at language and communication. I might say this on a later slide, but since it's in my brain now, I'm going to say it. I think that, it's important to also explain, if something comes up, just to explain like, hey, this is the way I was taught. I didn't realize that this was something that was important, and I'm going to go and I'm going to do some research and reading on it. Thank you for letting me know. Right. And that is just such a humbling experience. Whenever I've been to, let's say, a medical provider who's like, you know what? I'm so sorry. I got that wrong. Thanks for letting me know. The feeling that I have coming out of that appointment was like, oh my gosh, like this medical provider cares versus someone who, will just kind of keep doing what they're doing, even if I've expressed discomfort or tried to correct somebody on my experience. And so when we think about language, these are just some ideas to start to integrate into practice to, move into more neurodiversity affirming care. Um, when we look at a lot of the literature, especially in regards to cultural humility and learning, there is a lot of information about building pride. And so if we start to think about other minority communities that you may be a part of or that you come in contact with or support, there's a lot of movement towards pride and identity within those communities. Um, and I think that this is a really important piece that we can start to integrate into ABA services. So when we are thinking about building pride, we are talking about you know, the framework that we're moving away from, so the neuromajority framework into more neurodivergent framework. We're looking at autistic individuals working to reclaim this psychiatric diagnosis, like autism or ADHD, and really making it about acceptance and taking pride in who they are, right? We're looking at taking pride in the identity is really kind of where we're at. So some of this is a little bit repeating because I think they're really important foundational parts of neurodiversity affirming care. So again, shifting away from person first language. Um, the core part of reclaiming that kind of diagnostic label is developing pride. If we're talked about deficits and things that are wrong, it's hard to have pride in deficits. We're talking about strengths, we're talking about diversity, we're talking about individual, I always say individual awesomeness. I know that's not like an actual term that you'll find in any of the literature. Um, so Cooper et al., not the ABA Bible Cooper, but another Cooper, found that having a positive social autistic identity. So we're looking at how autistic individuals perceive themselves within the communities and within society, right? Having a positive view can increase social connections to their community, can act as a protective factor against mental health diagnoses and symptoms kind of later in life. So it creates protection because we're moving away from pathologizing autism, right? We're moving away from that. It has a significant decrease in the risk of suicide, and the autistic population has one of the highest rates of suicide attempts, and they have one of the highest rates of completion of suicide. And I think that that's a really important thing for us to think about as BCBAs if we are working primarily with the autistic community, is understanding that the risk factors are pretty significant for mental health symptoms and for suicide. And pride also can help battle both external stigma, so that's stigma in other communities, but also can help manage what's called internalized stigma, which develops because of the deficit-based language of the neuromajority. And so I think that that's another piece that's really important to think about. Chapman and Botha, they did a research study where they interviewed 20 autistic individuals. And they found overall, like overwhelmingly, that when they reclaimed autistic as part of their identity, there was a significant reduction in internalized stigma. Because again, that positive shift about this is, who I am and having pride in who I am, versus kind of like, oh, there's something wrong with me because the community that is in the neuromajority is telling me that something is wrong. This, kind of looked at really helping autistic individuals when there's pride, like have ability and willingness to communicate to the neuromajority. And that's where that advocacy part really starts to come in. So as BCBAs, how do we support our clients in building pride? And again, part of it is being aware of our own implicit biases and ableistic views. I grew up, so I'm diagnosed with ADHD, and that's my preferred kind of way to look at it. And I, really align myself with the neuromajority. And so a lot of my belief systems and values, I'm 43 years old. So, kind of thinking about my lifetime, how much the neuromajority has influenced my identity and how much it's influenced how I interact with others. And so it's really hard work to be aware of these things. And when I engage in language or behaviors that are, implicit bias or ableistic, it does impact the ability to support our clients in building pride and self-efficacy. Celebrating differences and celebrating diversity can be really important. I told one of my clients the other day, that they had cool brain because we talk a lot about brains. They want to grow up to be a neuroscientist. So I make little jokes sometimes. That's kind of our thing. And when I started working with this person probably 6 months ago, we would have not gotten anywhere. And they go, "You're right. I do have a cool brain." Right. So like really just kind of highlighting strengths and celebrating differences, recognizing achievements and helping people understand that achievements aren't always the really big accomplishment, right? We're not looking for the very end goal, but really starting to look at all those small accomplishments that the client can consider as progress, that we can talk about considering as moving in a direction that the client wants to go in. Creating a culture of acceptance. So this is a lot to do with the systems and the places that we work in. So we want to make sure that our clients know that they have access to safe spaces, that we are neurodivergent affirming, right? There's tons of materials and things that we can even just put up in our waiting rooms or put on our websites, or, kind of thinking about those things, because then our clients know that we're working to be more neurodiversity affirming. Having and supporting open conversations about diversity and like, what does that mean to each of our clients that we're working with? Providing choice and opportunity to explore interests. And then again, not only for us connecting with community and resources, but supporting our autistic clients and connecting with their communities, either locally or nationally. There's some cool international, kind of communities, and, supporting that in a really kind of positive and effective way. And so I mentioned on the last slide, providing kind of choice and, providing choice and trying to assess for preferences. This is something that has a lot of research and behavior analytic literature. It's, identified as a dependent and independent variable. Like choice is really kind of interwoven into a lot of the interventions that we are doing, because we're assessing for reinforcement. We're assessing for, ways that we can create environments that are supportive to learning and supportive to developing skills. And so when we're thinking about choice, we're really talking about providing an opportunity for somebody to express their preferences, build self-efficacy. And then also, I really love this term, like engage as partners in treatment. I mentioned in lesson one that, when somebody walks in our office, there's automatically a power dynamic. And so being really cautious about that dynamic when we work in partnership with our clients and their caregivers and stakeholders, we create more ability for, more positive treatment outcomes and engagement in treatment. When we're talking about assent, and I won't spend too much time talking on this because Amy has a training on assent. I think it's called Assent, Voice and Choice, Assent in Action and ABA Services. Did I get that right, Amy?
Yes, voice and choice. Assent in action.
So I really do encourage you to check that out, because it will do more of a deep dive into assent and how we put that into action into the ABA services that we're providing. Um, but just kind of understanding that assent occurs when an individual agrees to participation in an intervention. Assent can be vocal or non-vocal. And this allows for us to engage in more affirming and client-centered approaches with like our clients and families. Um, one of the core pieces of trauma assumed care also is making sure that we're providing choice and assent, and this allows for us to engage in more compassionate care as well. Um, it gives a little bit more autonomy and building of some of those softer skills, even in the context of treatment for the clients that we're working with. Um, and so we don't talk about consent because consent tends to be a more legal term of like somebody's giving me legal permission to provide blah blah blah. So I did say the word informed consent earlier. I need to work on my language. I feel like it needs to be informed assent. So really talking about like the services we're doing, how are we assessing assent, especially for individuals who aren't able to clearly or vocally communicate assent. Um, and when we can start to do this and, BCBAs, we engage in assessing this appropriately, recognizing and putting into place when we can recognize like assent withdrawal procedures, really, kind of paying attention to behavior and language, we are able to provide more neurodiversity affirming care. I remember when I was going to my ABA, Master's in ABA program at Ball State, they had us read the Bannerman article. Um, I can't tell you the whole title, but in it, it says, "Eat too many donuts and take a nap." And we were assessing, it was one of the discussion posts that we did, right? Because I did online school. And so kind of looking um, at the time, and this article was written in 1990. So if you are going to read it, some of the language and things, are of the 1990s. But it probably is one of the first article, like peer-reviewed, articles that really talked about how we balance in the client's right to rehabilitation, to goal setting. He talks about in the article, like if our client identifies that they want to eat too many donuts and take a nap, like how do we navigate that as BCBAs? And it kind of started the conversation and framework around clients' right to choose in treatment. And I'm hoping that since that time, some of the discussions may look different if we had them now with new information and listening to the autistic community. And we had to do like this debate around it. So I was, of course, on the side of like, no, the providers always choose, which is not something that I like sit in comfortably. Um, but really we're looking at, what does self-determination look like when those opportunities for self-determination are present? What does it look like to make sure that we're providing choice and assessing assent? Because if choice is not provided or like as BCBAs, we are making choices for our clients, we're really looking at the difference between like building autonomy and helping our clients generalize behaviors. And I always live in a place that my goal is to help my clients not have to be in services unless they want to, right? Um, and, how much am I looking at choice and assent and protecting the dignity of the clients I'm working with? Um, we talked about ethics a little bit earlier, but really, protecting dignity is part of our ethical obligation as BCBAs. And that really looks at, building autonomy and giving choice and listening to our clients' voices. Um, and then kind of the last part, I think, before I talk about social location is looking at social validity. So I feel like I've read the Barrett All article so many times, and sometimes I just reread it, right? Because it's our foundational article that was published in 1968. They talked about 7 dimensions of ABA, and one of them is social validity. There's a Wolf article from 1978 that talks a little bit more about social validity and really defines it to include how we're setting goals, the procedures that we're using, and the effects of our services, both intentionally and unintentionally, which I think is such an important statement. I can engage in what I believe is my best practice, is the best, in the best interest of the person I'm working with. And that will always have intentional and unintentional effects. And it's the unintentional effects that are what causes, kind of future harm if we can't assess like our own kind of belief systems and things like that. So I mean, again, I always give the disclaimer that sometimes language is interesting in older articles, but the content of defining social validity a little further. And that's kind of what's used even moving forward, measuring social validity now. So really we're talking about, in regard to social validity, who decides? Who are we working towards for social validity? Whose needs and wants are we taking into account when we're assessing social validity? So Pritchett et al. In 2022 did a review of over 50 years of applied behavior analysis experiments. And they looked at measurements of respect, beneficence, justice, and then the participation of the individuals in treatment. So they looked at all of those measures. And they identified that historically, ABA practice and research has overlooked the importance of participation of the client in how we're approaching social validity. And this maintains and creates the power imbalance that I've talked about in treatment. The other kind of piece that they identified was that when collaboration and social validity was assessed, it was usually assessed from the standpoint of the caregiver or the stakeholder and not the client themselves. And so the autistic individuals' experience, their choice, values, and preferences were not a primary assessment within the context of research and practice. And even further, showed less than 5% social validity measurements and indicators for the client themselves, which means that they only or often assessed only caregivers, collaterals, and the communities, as well as a social validity perspective of the BCBA without ever taking into account the client's goals and wishes. And so that is the unintentional effect that some of our interventions have when we're thinking about social validity. So some things when we're thinking about that in regards to implementing it into practice. Who is benefiting from a change in behavior when we are setting goals? I keep going back to my like social relationships. So if I listen to a caregiver who's like, my child doesn't hang out with anybody, they need more friends, and I never assess the goal of my client, and I build in social goals and interventions, who am I looking for a change in behavior to impact? At that point, it's mostly the wants and desires of the caregiver with good intention, right? I've talked to many caregivers who are like, I just want my, kid or the person I'm taking care of to have friends. Like I want them to have fun. I want them to feel happy, right? And so we're like, yeah, I want my client to feel happy too. I want my client to be engaged in their community, right? So now we're having this conversation around our best intention. We want our clients to be happy, and this is how we think it needs to happen. If I talk to my client and they're able to communicate, what their needs are, they may say, no, I have 4 best friends that I talk to when I play my games, and they're really cool. And I go to school with 2 of them. And I don't really want more friends. I am happy. I am happy with my friends that I have. I'm not happy that I can't sit still in class and that I have a really hard time when I get frustrated because then I like have to leave class, but I'm totally happy with my friends. Right. And so then am I, kind of thinking, oh, wait, how do I have that conversation with a caregiver? Right. So maybe I'm talking to the caregiver of, providing some education and talking about individual goals and talking about my autistic client's experience, or supporting my client in having that conversation with their caregiver. And then maybe my goals are aligned more to, with what my client is wanting to work on, because I'm going to build more positive relationships. I'm going to see more progress in interventions and the service that I'm providing because my client knows that I listened to them. And so how, thinking about how we start to balance when we have all these voices coming into, the things that we're doing, stakeholders, caregivers, are we also listening to our client's voice? Are we also listening to our client's needs? And then are the assessments and interventions that we're using affirming and client-centered? And a lot of the assessment materials we use right now are we're assessing deficit, right? So from a foundational place, our assessments are not super neurodiversity affirming. Many assessments were developed based off of behaviors of the neuromajority, which do not take into account minority groups, race, ethnicity, socioeconomic status, neurodiversity. And so, are we seeking out and getting training on how to engage in assessment in a more trauma assumed approach, a more compassionate care approach, which can then lead to more neurodiversity affirming treatment? So I'm going to talk about this. It's a little bit on the fringe of ABA, but I think it's really important in regards to how we engage in self-reflection, which is a part of our ethical responsibility. So social location kind of came out of the cultural diversity and implicit bias and racism trainings to start to talk about how our experiences in life, which include a combination of many factors. So it could be gender, race, ethnicity, social class, religion, the community that we grow up in, and really looking at how that informs how we develop our own identity, and then how that also affects how we see the world, how we relate to others, and then how we determine and define our own identity. It really comes out of the social justice movement in general. So out, not just within neurodiversity advocacy, but kind of within minority group advocacy, talking about, how our own personal experience as, I'm going to say for BCBAs, right? Because we're here for talking about ABA. So how our own personal experience as BCBAs informs our interactions and care that we provide with the clients that we're working with our peers that we engage with the collaterals that we're working with. So for example, I thought I would talk a little bit about what this might look like for me and how I've integrated this into services, just as because it is kind of a newer concept that is within some of the literature. But I will tell you that social location can help us engage in more compassionate care and identify implicit bias in our ableistic views if we're experiencing them. So I'm hoping this is not too small, but it's in the slides that are in the course. This is from the United Way for Southeastern Michigan. And if you go online and you search social location and click on images, you'll see a whole bunch of different variations of this. But this is, kind of thinking about some ideas of how we might start to look at this. So social location can be in regards to many things, but I'll just give you kind of an example if I was going to do my social location. So I am a 43-year-old cisgendered female. I have one brother. I grew up in a home with two parents who are still married to this day. They still live in my childhood home where I lived for the entirety of my childhood and moved back in a couple times when I was older. I don't live there now, but I had the opportunity to do that. I grew up in a fairly middle class community. My parents, we were probably like lower middle class. My dad and mom both worked two jobs, and we're blue collar workers. I grew up in a primarily white community. I had access to education. I had access to electricity and housing and transportation. I was able to go on and get a master's degree in therapy and a master's degree in ABA. So I'll just kind of stop there. We could keep going. So when I think about the information that I just shared, as I start to think about social location, right? Some people I might talk about the fact that I was diagnosed with ADHD in my 20s. I might talk about, some family history or interactions. What it starts to do is creates a picture of how my upbringing might influence how I engage in the world. So I remember going to college, and I went to a bachelor's college that was a primarily white college. And my kind of implicit bias is that everybody has access to education because I did. And I know now that I'm older that that is not true because I've done research and learning. But if that is the framework I come from, and I sit down with a family who is not white or who is not of the same social class that I am, or who has not had the same opportunities that I have, and I assume that everybody has access to higher education, my social location is determining my interactions with the person I'm meeting with, and that will come out in my language, which will also impact my relationship with the person that I'm working with in services. Um, there is a lot of really cool kind of development around social location. I think that's important to look into. In addition to getting training on cultural understanding and responsiveness, I think it went from cultural competence to cultural humility to cultural responsiveness, right? So we see the shift in language over time. And social location is kind of a very hard thing to do because you have to be able to sit down and reflect how your experiences may influence your provision of services. So, I think it's like a really concrete thing that we can start to do. And what happens is that we can then use it to inform how we start to shift our own behavior in how we're providing services to engage in more diversity affirming care. So this might just be like something that I have learned a lot from, and so therefore I am, sharing with you. It's not really in the literature for ABA yet, but I do think that we can operationalize some of these assessments and skills. And the social location was really informed by, like I said, the cultural responsiveness and minority groups and how we start to assess implicit bias and ableism. So we talked a little bit about this, but I'm just, coming to the summary, and then we'll talk about maybe some next steps I'll challenge you on some next steps to put some of these interventions into practice. Um, and, this has been in both lessons, but if I haven't said it 20 times, really making sure that we're listening to the voices of autistic and neurodiverse clients and individuals. Being aware of our own language and how we can start to shift our language to be more neurodiversity affirming, more trauma assumed, can be really helpful. Engaging in self-reflection to identify our own implicit biases and ableistic views. And again, if you're going to start anywhere with that, I really, from my own experience, have really benefited a lot from looking at social location, and looking at how my upbringing and my lessons I've learned and my access to education and my belief systems and values do kind of impact the care that I'm providing. And then it also creates opportunities to identify the behaviors that I can change. Again, seek out ongoing professional development. Genuinely, like I read some research and peer-reviewed articles in regards to affirming care that were written in like 2018, and then reading even some of the peer-reviewed information in 2023. It's vastly different. And it's important for us to access education and really do our independent, kind of research of the literature. And then, also kind of in regard to specific interventions and service, really focusing on the strengths of our clients' interests, what their needs and wants are, and what their goals are, can really help us engage in neurodiversity affirming care. From an ethical perspective, engaging in ethical practice, we're really looking at prioritizing autonomy, dignity, and the preferences of the people that we're working with. So next steps, both for what you can do in your practice, and then I'll talk about some, closing for the training itself. So I encourage people always to think about tomorrow, what is one thing that I can do to apply some of the information that we've talked about today? So what is one action step that you can integrate from the training? There are some workbooks that are going to be in the course that I think will be really helpful. There's an assessment and some self-reflection. If you're not really sure where to start based on it, like start there. They're guided, which I always love. I don't have to like think of too much on my own, right? I have some guided prompts that help me kind of do that reflection. Um, and maybe identify one autism advocacy or support network that you can interact with. And that could be just looking them up on the internet. That could be signing up for their newsletter. It could be reading some of the research and the articles that they have in the resource section. So thinking about one of those, what the kind of specific behaviors what the specific behaviors are that you can do that will help you connect with the communities in an effective way, because that will help us develop and learn and change our own behavior to support our clients in their care. So next steps for the course, this is the end of lesson 2. As was with lesson 1, there will be some quiz questions that you'll have to take. There will be a place that you'll have to check and certify that you watched the course in its entirety in order to access your CEUs and your certificate. There's also an evaluation. I love getting evaluations because it helps me learn what information I can continue to talk about. This is a harder training for me because I am not autistic. And so if I have made any missteps or, made statements that do not align with neurodiversity affirming care, I'm open to feedback so that I can learn and shift my language moving forward. And it also helps us just kind of understand, for learning styles and things like that, what we can shift moving forward. Amy, did I get all of it?
Yes, there will be instructions on how to update your BCBA number in the system in the mission accomplished lesson. So you want to make sure that you update that number before you mark that lesson complete. And you have to take both quizzes for lesson 1 and lesson 2 and mark the mission accomplished lesson complete in order to earn your certificate.
Thank you. I'll get it eventually.
All right.
But thank you all for attending. There are also places that you can ask questions and put in comments within the training. All of those comments get read and responded to. Amy does a really nice job, and I always love to read kind of what people put in and jump into those conversations as well. So thank you all, and I hope that you all have a lovely, well, it's evening where I'm at. I think where Amy is too, but if it's not evening, have a lovely whatever the rest of your day looks like.
Thank you, Nikki.